Dr. Morton Makar, and I'm presenting a case of double positive anti-GBM and p-ANCA glomerular nephritis. So to start off, anti-glomerular basement membrane disease is characterized by antibodies to type 4 collagen found in the lung and the kidney. More recent literature has shown that patients with anti-GBM disease have a concurrence rate between 10 and 50% with anti-neutrophil cytoplasmic antibody. So we have an 80-year-old female with a history of hypertension hypothyroidism that presented with abdominal pain, found to have severe renal failure and severe hyponatremia. So she was worked up for her AKI. Her sodium was increased appropriately, by 6 millimole a day. Workup was notable for a nephritic pattern, complement within normal range with PASI immune, and ANCA and anti-GBM antibodies were sent, and she got a kidney biopsy. So in figure 1, you can see glomerulus showing cellular crescent with fibrinous necrosis. And then in figure 2, you can see an example of smooth linear staining of the glomerulus with a basement membrane with antibody to IgG, crescent formation in the glomerulus as well. So this was consistent with severe necrotizing crescentic and sclerosing glomerular nephritis. So during this day, she had 5 rounds of plasmapheresis, pulse dose steroids, cyclophosphamide, and discharge on a prednisone taper and dialysis. She also, during this day, had some antibodies that came back positive as well, an anti-GBM antibody, perinuclear ANCA, and myeloperoxidase antibodies. So 7 months as an outpatient, she had some fatigue, some arthralgias, poor appetite, weight loss. And then after stopping her steroids, when she ended her steroid taper, she presented with respiratory failure. So she was intubated, had a CT of her chest, PE protocol. There was no pulmonary embolism, but there was infiltrates of bilateral lungs and then also pleural effusions, the left greater than right. So initially she improved with dialysis, she got extubated, but she was still on oxygen, and she was on oxygen for several days. After thinking about her arthralgias and fatigue and then having this p-ANCA positivity and myeloperoxidase positivity, there was concern about relapsing disease. So a bronchial and diffuse alveolar hemorrhage. So a bronchoalveolar lavage was pursued. Eventually the cultures grew Haemophilus influenzae. She was started on plasmapheresis in the interim, but due to her debility, we didn't really start immunosuppression, and she improved with antibiotics. So it was deemed that that this blood found in the bronchoscopy was likely not to be representative of diffuse alveolar hemorrhage. So anti-GBM disease is a rare disease. It's primarily diffuse alveolar hemorrhage, rapidly progressive glomerulonephritis, or both. In younger individuals, diffuse alveolar hemorrhage is slightly more common, while in older individuals, RPGN is more common. The occurrence rate is between 10 to 50% for double positivity. Retrospective studies have shown that people with only GBM antibodies tend to have a rapid decline in renal function. They present on dialysis, they're unlikely to come off. While patients with double positivity are more likely to be able to come off dialysis when they get appropriate immunosuppression. Double positive patients have a higher rate of relapse with either lung disease or systemic vasculitis. However, individuals with strictly ANCA vasculitis tend to have a relapsing remitting disease, and they're way more likely to recover kidney function with appropriate immunosuppression. So large case series have shown that double positive patients have clinical phenotype that's kind of in between ANCA vasculitis and pure anti-GBM disease. And if you can kind of look down at these slides down, these tables down here in the middle column, time to ESRD or death, and we have top line as ANCA-associated vasculitis, the bottom line, which is green, is glomerular basement membrane disease, and then double positive in the middle. And so this shows that people with ANCA-associated vasculitis with kidney dysfunction are either they're less likely to go to ESRD or death, while people with GBM are more likely to develop ESRD or death, and double positive is in the middle. And then if you can look at the chart right next to it with relapse, ANCA-associated vasculitis is the most likely to relapse, while people with double positive are kind of in between, and the people with anti-GBM disease it's a monophasic disease that happens and it's gone. So the real teaching point is physicians should note when GBM positive patients are positive for ANCA and have a high index of suspicion for those that are double positive because they may be at risk for relapsing disease.